Let's dive straight into this explainer. Today, we're cutting out all the conversational noise to focus purely on rapid, error-free clinical execution in neurocritical care. Because in the ICU, hesitation doesn't just cost time, it literally costs brain tissue.
Picture this. Right-sided weakness, 2 hours post-onset, and blood pressure is roaring at 200 over 115. Your immediate move? This forces a split-second choice. Aggressively titrate antihypertensives to hit the thrombolytic threshold, or fall straight into a fatal permissive observation trap.
To make that call, you have to track your timeline vectors strictly. IV TPA is unviable after 4.5 hours. Conversely, mechanical thrombectomy stretches up to 24 hours, but only for confirmed large vessel occlusions. You're racing a closing window to save that ischemic penumbra.
Your first diagnostic gate, the non-contrast CT head. Now, an acute negative CT doesn't rule out an ischemic stroke, but it absolutely rules out hemorrhagic contraindications, giving you the green light to initiate thrombolysis safely.
Let's talk about the hemodynamic red line. If TPA is indicated, dropping blood pressure below 185 over 110, using IV labetalol or nicardipine is absolute mandatory before dosing. Otherwise, you risk catastrophic cerebral hemorrhage. Not indicated? You actually allow permissive hypertension up to 220 over 120 to keep collateral perfusion flowing.
Before triggering the stroke cascade, account for the hypoglycemia mimic. Never initiate these heavy interventions without checking glucose. A level under 50 can flawlessly mimic focal neurological deficits. Check it first.
Module 2. Status Epilepticus Escalation.
Moving from ischemia to electrical storms where progressive GABA-A receptor depletion drives a dangerous pharmacoresistance. The absolute threshold? 5 minutes. If seizing crosses this mark, the waiting game ends. Immediate hyperacute sequencing is mandatory to stop irreversible injury.
Enforce this stepwise matrix without delay. At 0 minutes, hit Tier 1 with IV lorazepam to reverse hypersynchrony. At 5 minutes, if seizing persists, jump to Tier 2 with phosphiniatoin or levetiracetam. By 20 minutes, you're locked into Tier 3, refractory general anesthesia with propofol.
Don't miss this structural warning, the intubation mandate. Reaching Tier 3 infusions demands immediate endotracheal intubation. Initiating refractory general anesthesia without securing that airway and starting continuous EEG monitoring is a catastrophic error.
Module 3. Structural intubation thresholds.
Let's break down fatal diaphragmatic failure from neuromuscular crises. Guillain-Barré syndrome, GBS, brings ascending paralysis. Myasthenia gravis, MG, involves autoantibodies showing up as bulbar weakness and severe fatigability. Both drive respiratory collapse, but their mechanics differ completely.
Regardless of pathology, monitor these absolute respiratory metrics every 2 to 4 hours. If forced vital capacity drops to 20 milliliters per kilogram or less, or negative inspiratory force hits -30, execute immediate elective endotracheal intubation. Don't wait for arterial blood gases. Pulse oximetry will falsely reassure you until terminal exhaustion hits.
Watch out for the steroid trap. Corticosteroids are strictly contraindicated in GBS. Hitting an acute GBS patient with high-dose IV steroids is a massive error that prolongs recovery. Treat with plasmapheresis or IVIG instead.
Module 4. Clinical reconciliation and disruptive neurological traps.
In the real world, conditions don't wait their turn. 0 hours, acute ischemic stroke. 2 hours in, generalized status epilepticus. By 6 hours, rapid flaccid bulbar weakness. It's a cascading nightmare demanding flawless execution across overlapping, life-threatening failures.
So, I leave you with this. How do you simultaneously sequence nicardipine for the stroke, anticonvulsants for seizures, and airway protection for a collapsing diaphragm? You must master these data matrices and execute without hesitation. Are you clinically prepared for the next critical fork? Thanks for joining this explainer.